For most of the last 34 years, I've had the great good fortune to be a family doctor in County Kildare, which, as some of us know, is 55 kilometres over that way. I've been lucky to work with an amazing team of people, but unfortunately, a lot of our patients have died. It happens all the time. What I'd like to reflect on over the next while is why some of those people who are dying seem to make a really good job of it, they and their households, why a lot in the middle of the curve have a kind of a mixed experience, and why a significant proportion of people have a terrible experience around it. So whether we're in the global south or the global north, there's a lot of death around. I think 53 million people die on the planet each year. And I think the experience is enormously varied. As global health practitioners, I really hope over the next 12 or 14 minutes, we might collectively get more curious about this. It's something we all push right to the end of our bucket list. I won't die till I'm ready to die, but it creeps up on us. I'm aware that in our group, many of us will already have been touched by death, but it is remarkable the extent to which we can push that out and get back and get completely consumed by the things we're doing next. How we die really matters, and I think it's really worthwhile considering how we can actually create the best experience for ourselves and especially for the people that we leave behind. Thinking back, you might have had moments or times where death touched in your life. The first time I thought of death in any sort of meaningful way was 2 kilometres over that way in St. James's Hospital as a senior medical student, as a junior hospital doctor, and the arrest bleep would go off and we'd all run off to wherever the arrest was. It was barely organised chaos, and we ran up the stairs, we did the chest compressions, and you weren't doing a good job unless you broke several of the ribs. Some of us tried to get IV access, somebody managed the airways. Most of the time the arrests weren't successful, and you left feeling really, as a 19 or a 20-year-old, not quite sure what you were feeling. But there was a smell, there was the rubbish of the arrest. It was awful. Going back down the stairs, I was thinking, wow, so that's what it is. That's the end of it. And then, of course, being a young man, I didn't think very much about it again for at least 10 years. And going into practice and building up the practice, very, very busy. And I got this call out of the blue. Conscious we're an international audience. Part of the Irish psychology is that every Irish man believes that he has the best mother in the world. So she rang me, and out of her busy clinic in inner city Limerick, which was a difficult station, she said, "You need to understand, one of these days I'm not going to be here. I need to get my stuff organised and you're going to help me." So I did what all young Irish men do to their mothers, and I just brushed her off. I couldn't actually think that she wouldn't be there at some stage. But she knew that that was going to be the case. She rang me a second time, and then I really knew that she was serious about it. So with some degree of trepidation, I went down to where she lived, and we spent 3 or 4 hours in her living room discussing everything. She had it all organised in her mind, and she communicated it to me. The trepidation disappeared after the first 5 or 10 minutes, and we put in an amazing morning. And yes, there was business, there were things that had to be decided in documents, but really the whole morning really caused us to think about her life. And I left thinking I completely had the most wonderful mother in the world. Then I went back to practice and didn't think about it very much again. About 12 years ago, the Irish Hospice Foundation, which is one of our fantastic NGOs in Ireland, came out to our training scheme in Tala Hospital, which was 10 kilometres over that way, and they brought this out. It's a thing called Think Ahead. Well, it's old-fashioned technology. It's paper and stuff. It's an end-of-life planning tool. And they said, we've just designed this. It's come out of the Forum on End of Life in Ireland. And it's one of the things we've decided that people have said that they would like. They would like some guidance around planning their end of life. And here it is. Could you do something with it? So we had a look at it and we said, well, this looks interesting. So yes, this is what it is. So it's a plan, okay. And yeah, we could. So what we decided to do is we designed a small study. We took it into 5 training practices and we gave it out to 20 people in each practice. These were people like you or you or you or you. They were coming along for their cholesterol and blood pressure check, for their menopause check, for their diabetes check. We gave it out to them and we said, we're seeing what you think of this. Will you come? And we gave them a phone call at 2 weeks and 3 weeks to see how they got on. The GPs in the practices weren't all that pleased about it. So you want us to give this out. It's a document about dying and everything that could possibly happen. They're not going to be very pleased with this. They're going to come back. They will be confused. We'll upset them. It's going to cause all sorts of awfulness. But that's not what happened. They largely didn't come back. If they come back, they have usually 1 or 2 or 3 very specific questions that are actually very easily answered for the most part. So the questions we asked, how did you find getting this from your GP when you were in for something else? Most people had no difficulty with it. When you got this, were you able to complete it? More than 80% were able to complete a lot of what was in it. It's a series of important checklists of things that you need to get organised as you approach end of life. We asked, did it upset you? 77% indicated that this document, all about my death and dying, didn't actually upset me. We got some information about things that were upsetting and we improved the end-of-life planning tool. Most importantly, we asked, when you got this, did it cause you to have a discussion with somebody else? And 80% indicated that yes, it did, either completely or to some extent. So this is very inexpensive and it really works. Emboldened by this, we did a second study on a different group of patients who we understood were likely to be within 6 months of their death. So they were much frailer. They were end-stage prostatic cancer, end-stage heart failure. And we got very similar responses, but there was one significant difference between the 2 groups. The younger, earlier group had a much higher level of completion. They were able to engage with it. Whereas the people who were closer to their time of death were less able to complete it. So a big learning from that is, the sooner you start this end-of-life planning thing, probably the better that it is. So, in terms of end-of-life planning now, what does it mean now? What does the evidence tell us, and what does our practice tell us? I think in the round there are many times to do end-of-life planning. There are many answers to when is the right time to start it, but there are 2 bad answers, which is never or later. In our practice now, anybody who's over 70 gets one of these automatically. Anybody who's had a life-limiting or a life-altering diagnosis made, if you've type 2 diabetes, if you've got breast cancer, you get one of these. And then periodically, every 1 to 2 years, we'll ask, we discussed your end-of-life planning, is there anything you'd like to change? No, it's good, that's exactly what we're doing. So it's inexpensive. If we look around the world now, most health systems in most countries have these. Now, doctors are funny people, really. There are certain things that we like. We love diagnosis. Diagnosis is the great game of hunt the slipper, what's causing the problem, and everybody's getting in on that act. People armed with Dr. Google like diagnosis, everybody loves diagnosis. We like management plans. We love plotting and planning. What are the best drugs? What are the additional therapies? How does this need to be done? And we're grappling with this all over the world, in the global south and in the global north. But we hate prognosis. We don't like looking ahead and what's likely to happen, which is a bit of a pity because the evidence suggests that if we actually decide to be better at prognosis, we can actually get very good at it without too much difficulty. So you, in your global health work, whatever group you're working in, whether it's a clinical group, whether it's a research group, whether you're trying to affect policy, can I ask you today, can we all consider that in every one of those activities there should be a little bit about end-of-life planning? I mean, the diabetologists love talking about diabetes. They'll talk about it till the cows come home. They will plan every device and technique and medicine and delivery system. But they often forget, as do all the other disciplines, that all the people with diabetes will sooner or later die, and often it's sooner. So going back to the people at the top of the bell-shaped curve who have a really good experience, what are their secrets? What do they actually do that seems to make a difference? Looking at the international evidence, looking at the evidence we've generated in our own system here, and looking at practice, I would think that there are 7 steps maybe that you can usefully take. You can take them yourself at a personal level, and you can take them as a global health practitioner. The first is to take control of your own death, that it is yours. Don't be a victim of the acute hospital system. Don't be a victim of the politicians. Don't be a victim of your family about what they think is the right thing. Figure out yourself what you think is the right thing. Think about it a little and often. I find when I think that one of these days I won't be here, I generally turn up better for people. I turn up better for my family. I turn up better for my patients. It's a kinder world when we think like that. Identify your trusted friend. And who is that? It's somebody that you can have just a couple of deep, meaningful conversations about what's important to you. What do you want as you approach your time? And once you have your trusted friends stitched in, they'll often do for years. Sometimes there's a need to change them. If you divorce your trusted friend, you've got to find another trusted friend. But can I say, it is a universe of love, and it's full of trusted friends, but just pick one out and have those discussions. Complete your end-of-life planning document. And make sure you do it. Typically it takes 40 or 60 minutes to do, which is the hardest time you do it, and then refresh it every now and then you're up to speed. Understand how it is that you're likely to die. Those of us in the global north, we have a 1 in 4 chance of having significant impaired cognitive function or dementia. So it's really important to have your trusted friend, isn't it? And in the global south, different things happen to people. So when we go into any of the many places, find out how it is that people die, find out what is the culture around dying, death and bereavement in Mzuzu in Malawi, as well as in Mullingar and Westmeath. Understand that, just build that into your imagination. Understand what it's likely to die, what it feels like to die, and what the expectations are, whether your faith background is Muslim or Christian or agnostic. Just be aware of that. These are simple, easy things to do, and they generate the conversations. For those of us in the global north, practice the decision, we've had enough medical care. Over-medicalization at end of life is a really expensive, painful thing. Practice the decision, no, I've had enough. Doctors are quite funny about it. The evidence suggests that when our time is coming up, we're actually very forceful at saying, no, I will not have that extra chemotherapy, I will not have that morphine, that operation. I would like some morphine, and I want to go home to be with the people that are really important to me. So it's universal what makes a good death. It's privacy, it's dignity, surrounded by your friends, by the people that are really important to you. It's good symptom control, which is relatively inexpensive. Should we choose to, we can all do better with this. Thank you for listening.